Thank you for joining us today. My name is Susan Evans, and I'm honored to welcome you to today's webinar for an enlightening discussion and to explore different types of dementia with our caregiver expert team, Monica Moore, Tammy Anastasia, and Lisa Bricker, with a very special guest that I know you will all enjoy is Dr. Jennifer Pauldurai. Welcome. Today, we will address the questions of millions of caregivers that they have, the why and the how behind the different types of dementia and the challenges associated with them, specifically FTD, CTE, and alcohol-related dementias. We will dive into a caregiver perspective and then explore a clinical perspective. Thank you, Kensington, for supporting these powerful educational events. I was first introduced to the Kensington family in 2015. Our family made the difficult decision to move my father to Kensington in Northern California, who was living with Alzheimer's disease. My life pivoted from being an empty nester to dedicating my efforts to education and connecting the Alzheimer's community. Kensington focuses on relationship-based care, care built on the foundation of the promise to love and care for your family as they do their own. Thank you, Kensington, for keeping us current and supporting these educational events. Please utilize the Q&A function to submit questions during the webinar. We are hopeful that today will be a conversation with you. Caregiving is personal, and we all have unique challenges. Please ask our team of experts. A copy of today's webinar will be delivered to your inbox in the next few days for you to share with friends and family, and of course, watch again. Please join me in welcoming Monica, Tammy, and Lisa. Thank you again for joining us today. Hello, Monica, Tammy,
Hello.
Lisa.
Hello there.
Let's go ahead and start for the audience, introduction from each of you. And then I know you guys are going to help lay the framework for today. And then we'll introduce Dr. Jennifer Pauldurai. And Monica, why don't we start with you?
Yes, hi everybody. Good afternoon, good evening. I work at the UCLA Alzheimer's Research Center, also known as the Mary S. Easton Center, where we focus on caregiver support, research, clinical trials, and also being a place in Los Angeles where people can come and get a proper medical evaluation, and where we do have doctors who specialize in the different types of dementias and really trying to focus in on how can we help support people on this journey of dementia. Tammy?
Okay, my name is Tammy Anastasia. Thank you everybody for joining us today. I am a dementia consultant, educator, support group facilitator, speaker, and the author of Essential Strategies for the Dementia Caregiver, Learning to Pace Yourself. I have a private practice and I primarily work with family caregivers taking care of a loved one living with dementia. And I provide dementia guidance, emotional support, care strategies to family and also professional caregivers as well.
Before you introduce Lisa, I knew I was going to do this. Dr. Jennifer, I'm just going to call you Dr. Jennifer. Dr. Jennifer's last name is Pauldurai. So I'm so sorry that I mispronounced that. But go ahead and join us. But Lisa, go ahead and then we'll let Jennifer take it away.
Hello everyone. I'm Lisa Bricker. My company is called Gently Guided. We are mostly Alzheimer's and dementia placement specialists. I am a recovering family caregiver. My husband was 55 when he started showing signs of Alzheimer's, and it was very challenging. It was back in 2005, and we had a 15-year journey. It took over 7 years to get a diagnosis. So there was a lot of confusion and frustration along the way. And I quickly became an advocate the hard way, as everyone else does, as we face this disease many times. It was not on the travel brochure for sure. I've been doing this work. I started doing this work over 13 years ago in helping families find the appropriate living options, and I also do provide a support group. It is just an honor to be with all of you, and we always enjoy the questions that you ask and the education that we can provide. Thank you.
Thank you. Before we get going on the presentation from Dr. Jennifer, Monica, can you kind of lay some framework for the audience to better understand what we're talking about today?
Absolutely. So I'm going to pull up my screen here. And one of the things that when we do these presentations, we realize the importance of making sure that everyone understands, the terms and the words and everything that we are talking about, and making sure that we're all sort of on the same page. So one of the things that, really, especially in this world of talking about the different types of dementias, that it's so important that everyone understands, what does this mean? What does this word dementia mean? And what is the difference? And we'll talk, obviously, Dr. Pauldurai will talk much more about this. But for these purposes right now, we just want to talk about this word dementia. This word, it is a word that describes a group of symptoms. Dementia in and of itself is not a clinical diagnosis. It is this, takes two factors. One, where on the left-hand column, it's a cognitive decline. We're having problems with thinking, language, memory, reasoning, judgment. That is different from your baseline. And then it's also now having a functional impairment in your daily life, where problems with taking medication, driving, paying bills, etc. So let's say, for example, you are having problems with your judgment that is now impacting your ability to take your medications. You're having problems with your thinking that is now impacting your ability to drive safely and to drive. So we look at, it's really these two things together, which then would be a doctor would say you're having dementia type symptoms. So let's figure out what is causing these symptoms. So it's also very important to know that dementia is not normal. It's not a normal part of aging. This shouldn't just be expected. You're 85. What do you expect? You should have dementia. Not at all. So this is why these conversations like we're going to have today are very important. We look at this word as an umbrella. So underneath the umbrella of dementia, again, a word that describes symptoms. In and of itself, it is not a diagnosis. There's all of these types of dementias, plus more than I could fit on this screen. So today we will be talking much more. We'll be talking about frontotemporal dementia. We'll be talking about CTE, and then we'll also be talking about alcohol-related dementia. So also, underneath this, we see Alzheimer's, Lewy body, Parkinson's, which we talked about 2 weeks ago, stroke, vascular dementia. So realizing there's lots of different diseases and that can cause dementia. So one of the things when we do these presentations, it's really hard to find really good graphs that really break down the incidences of disease, of Alzheimer's and vascular, the different types of dementias, because lots of them are maybe not as frequently diagnosed. They are harder to diagnose. People don't come to the doctors for diagnosis. So Alzheimer's is your most common form of dementia. After that, vascular dementia, mixed dementia, frontotemporal dementias, and then other dementias. So sort of, a crude breakdown of these types of dementias. What we'll talk about today falls into the other category, or also the mixed category, as well as the frontal dementias. So hopefully this has helped you at least get a little bit of a framework and an understanding of what we're going to be talking about today. So I'm going to stop sharing here so you'll get all of us back together. And then one of the things we really talk about is the importance of understanding why a diagnosis is important and why a specialized focused diagnosis is very important. So for that, I'll actually turn it over to Lisa to see, so that she can shed some light based upon her experiences as a professional and also as a family caregiver, talking about why this is important.
I think there are so many variations of this disease that it's so confusing. My husband was diagnosed after 7 years with Alzheimer's. It wasn't till we went through many, at least 6 neurologists over a course of time. The third one diagnosed him, and we continued to progress. into, continuing to see neurologists. He was eventually diagnosed with a mixture of Alzheimer's and frontotemporal. And because he was not making good executive decisions, he was not making, he even was trying to drive, he was denting the car, but his thought process was really off. And had been an attorney, and in his right mind, he would have never been doing these things. It's in my line of work, we see so many different types of dementias, and I'm curious to know what Dr. Pauldurai says about some of these because I'm very curious because seem to have had a correlation uh, when I see vascular dementia with alcohol-related dementia. And I was wondering if there was a correlation, and I know that it is very complicated, as have you shared. So we see Lewy body, we see what we're not talking about that today. It's really important that the appropriate approach, the appropriate medication, the appropriate environment, and the family members all understand what they're dealing with.
I'll chime in. It's really, really difficult to decipher between the behaviors that you see what a diagnosis is. So I think families want to really document and really keep track of the behaviors, the nuances, the changes, whether it's personality, whether it's thinking, whether it's language, whether it's processing, memory, and really document because in order to really try to hone in on what type, the more we can share about what we observe and what we experience and how it's different and how it's changed. We all have a baseline, but how out of characteristic is these changes that you're seeing, the more information we can share about what we're observing and experiencing as a family member will help hopefully guide and direct us into what direction we might need to go in testing because there's a lot of overlaps between all the dementias. So I guess one of the questions I'll ask Dr. Jennifer is, how do we differentiate? Like, how do we really test for the different dementias and what are we looking for that is significant that says, you know what? This is the hallmark signature for frontotemporal. This is the hallmark signature maybe for alcohol-induced or related dementias versus the difference for Lewy body, any other dementias, and even the traumatic brain injury. So I think we don't want to underestimate the value of our observations as the caregiver and really take note and write down because that frequency and what's occurring, what's changing, what's the intensity will all be really, really helpful information to provide for the doctor in helping direct which way we go in terms of figuring out the diagnosis.
I think I'm going to take that, Tammy, and I think I'm going to use this opportunity to properly introduce Dr. Pauldurai so we can really hear the information that she has. Again, we want to hear from the professional, the person who went to medical school and who really understands this world of diagnosis. So everybody, let's please welcome Dr. Jennifer Pauldurai. She's a board-certified adult neurologist with special training in cognitive and behavioral neurology. She completed her adult neurology residency at George Washington University and then pursued fellowship training with the Cleveland Clinic Lou Rovo Center for Brain Health in Las Vegas. She holds a master's in integrative medicine from George Washington University. She currently works for Innova Neurosciences, and her clinical interests are memory disorders, dementia syndromes, and integrative lifestyle and behavior modification. She enjoys providing health education for patients and caregivers and believes that understanding brain wellness is the first step in lessening the burden of brain disease. So we are incredibly grateful that you are here with us today, and I'm going to turn it over to you at this point.
Thank you so much. I really appreciate the warm welcome, the introductory questions. That setup was perfect. before I jump into all of the science, I do want to say, sure, I went to medical school, sure, I got training and how to diagnose this stuff, but I'll be honest, the majority of what I do on a day-to-day basis is learn from people like you, from caregivers, from families, from humans that are going through the experience of a brain illness, and that's not taught in a textbook, that's not taught in a webinar. So I really want to applaud all of you who are joining us today in this webinar. That shows that you care. You want to live this life better. You want to help life for somebody else a little bit better. And we're not going to get it right every single time, and that's okay. But the fact that you're here and willing to learn is already a step in the right direction. So thank you for joining us. I'm going to share my slides if that's okay. I wanted to just take a few minutes to just go through brainy stuff, like an anatomy lesson really quick, and then we'll jump into questions and kind of how this relates, okay? I have to figure out how to share my slides. This is the hardest part for me. I am technologically challenged, but I think I can do it. All right, can we see that okay?
Yeah.
Yeah,
Looks good.
perfect.
We
All right.
can.
Perfect. So let's talk about atypical dementias. I like the word atypical because, not because there is a normal or not normal, but because I think people like to visualize dementia syndromes as one specific image, textbook image of someone who is forgetful, someone who repeats things perhaps. But that's not the only thing the brain does, right? As we have learned in our first part of this series as well, the brain does everything from walking to talking to making decisions to driving, to paying the bills and cooking. So how can a brain dysfunction all look the same? And then add on top of that all of our personality, all of our interesting quirks, right? Like how could we all look the same? That is why I like to use the word an atypical dementia syndrome. We're going to go through these three in particular, but I'm going to start off by actually going through some specific ways that we can sort out what's what. Because as Tammy was alluding to earlier, it's really hard to tease out, well, this seems to be changing, but that's kind of how he always was. And how do I know if this is just like his personality, or how do I know if this is a disease? And actually, a lot of that information, my diagnostic process, a lot of that actually comes from what you tell me. So you were absolutely right. And how well you describe dysfunction is very important in me understanding the story. The best number one diagnostic tool I use is you telling me I know this person for 50 years and this is not him. This is what has changed. I want to hear, is it a thinking problem? Is it a walking problem? Is it an appetite problem? Describe for me your loved one and why it is that you think something is wrong, because that's really important for me to figure out what's going on and what's changing in the brain. Because I can take MRI scans and CT scans all day long, uh, that might not answer the question. Actually, there are tons of people with dementia that have normal MRI scans. And then I have people with MRI scans that have brains the size of walnuts, but they look fabulous. So MRI scans are not the answer. PET scans are not the answer. Even blood tests are not the answer. Genetic tests are not the answer. All of those are clues as part of this puzzle, but it's driven by that base definition of dementia is a decline in function where we cannot take care of ourselves anymore because of a cognitive change. So we use all of these tools to put together a story. And I saw a question in the chat. I'm going to address this too as I go along. Understanding a specific diagnosis, I think Lisa alluded to this earlier, is very empowering to know what to expect, right? Because there's some types of dementias that cause falling. I think we talked about that in part one. Some types of dementias cause hallucinations. Other types of dementias cause paranoia, but not all of them do. So is this normal for my dementia? Is this unexpected? Is this another brain problem? Right? And having that knowledge about what to expect and how to relate to your loved one is just more accurately driven when I have a specific diagnosis. And I can say, you have FTD. This is what goes wrong in FTD, and this is what we can expect now, and then this is what we can expect a few years down the road. Sometimes, in more advanced dementias, our brain turns into a mixed bag of gunk. We get a little sprinkle of this and a little sprinkle of that, and it all kind of overlaps and looks the same. At that stage, yeah, you're right, Dee. Sometimes we might not know what specifically relates to what. And that's okay. That's all right. Another thing I got to throw in here, and this is a little bit off topic, but If I know that it's Alzheimer's disease, for example, there are disease-modifying treatments available for Alzheimer's now. There are specific support systems that I can do if I know that you have Lewy body. There are specific behavioral modifications we can focus on. So treatment planning actually changes when we know what type of dementia too. So medications might be different, treatment planning might be different, and also just you as a caregiver and a loved one, you will have better power, more information as power to know what to expect. So that was kind of a sidetrack, but just to understand why this is important, because back in the day, there didn't used to be a whole lot of me. There weren't a lot of people that did cognitive behavioral neurology. Everybody just said dementia is dementia. It doesn't matter. Who cares? Who cares? There's something going on in the brain. It doesn't matter. And we didn't have the tools that we have now to accurately diagnose the disease and really help people with the treatments. We don't have a cure to most dementias. We're getting real close, but imagine how even more powering that can be if we had a specific diagnosis and then I can say I have a treatment for it. I have a cure for it. Okay, so step one, understanding the diagnosis is going to be life changing. Step two, doctors are going to help you figure this out. You don't have to WebMD it. Okay, we've got tools, we've got stories, we've got images, so we'll help you through it. Now, I have a few slides here about kind of normal brain function and what can go wrong when these networks change. I think that can be helpful for us to understand the kind of atypicals. So, this is a lobe that we're all familiar with, and I think we talk about this one more than the others. This is the temporal lobe. The temporal lobe is the one that helps us learn and remember and think, so that if there is a problem in the temporal lobe, you could say something and it just kind of falls through the cracks. It just doesn't stick. It's like a memory bank with a crack in it, and just things just don't stay. And maybe they used to stay, so you remember your war stories and your childhood stories, but the more recent what you had for breakfast just slips on through. And that's because the memory bank was working. But now there's a disease that changes the way that it works, and so it just slips. The temporal lobe also houses our language centers. So a lot of people with temporal lobe change can have aphasia, language, understanding, and speaking trouble. Okay, but this one gets a lot of attention. The temporal lobe gets a lot of attention because this is where Alzheimer's likes to go. I want to tell you a little bit more about some of the other lobes because this is what makes some of the atypicals atypical. Okay, let me tell you more about the frontal lobe. The frontal lobe is the executor, the chief, the CEO, the director of most of our brain activities. It helps with organization, with planning, with judgment, with prioritization. And when the frontal lobe is not working well, when there is a dysfunction there, then it can look like too much activity. I want you to envision someone with ADHD, for example. They don't know who to pay attention to. What's that? What's that? What's that? Because their CEO is out of town. Okay. But it could also look like the opposite, where I don't want to do anything. I don't care about anything. I'm just going to sit here because my frontal lobe's not working. So the frontal lobe actually changes behavior and mood and some of the personality a little bit more than the temporal lobe does. So this is important for us to remember when I start talking about some of these atypical syndromes. Okay, the frontal lobe is the one that helps direct our system. It's the CEO of this system. Okay. Another lobe that kind of works hand in hand with the temporal lobe and the frontal lobes is the parietal lobe. The parietal lobe is a problem-solving lobe. I call this the IKEA lobe, the one where we have to figure out what to do first and which screwdriver to use. So if somebody's got a parietal lobe problem, they might not understand, oh, I got to call this person first and then do this. Or something that used to be very simple for them to follow, maybe a recipe for cookies, is now overwhelming because I just don't know, do I put this kind of sugar and what do you mean 1 cup and do I put this first? Does it need to be refrigerated? That's not necessarily memory. That's a problem solving. It's a processing part. The parietal lobe is actually also the part of the brain that helps us with stimuli like sensations and sensory regulation. So someone with parietal lobe dysfunction might not understand hot and cold. They might not understand sights and colors. They might not understand sounds. They hear something and they think it's very close to them when actually it's very far away. That's processing that our brain does unconsciously right now. We don't have to tell our brain to understand what we're looking at. But now imagine if that part of the brain is broken and we see a shadow and we think it's a snail. That's our brain not processing correctly. Okay. So it's not just our brain playing tricks. It's actually because there's dysregulation. There's a problem in that center. parietal lobe is actually right next to the occipital lobe. The occipital lobe is our vision processing center of the brain. This part of the brain helps us understand what we are seeing, depth perception, colors. So sometimes our eyes can be completely normal, but our occipital lobe can be broken. For example, there's a posterior cortical atrophy variant of Alzheimer's disease. That's another atypical, by the way, which is just a vision variety version of Alzheimer's, where someone might not be able to understand what they're holding. Like they'll describe for me, I was holding a hand of cards and then something fell and I didn't even notice it. That's not memory, right? That's not the typical dementia picture that we all describe. No, that's a vision processing. Or someone will tell me I keep sideswiping when I'm driving, I'm running into trash cans and don't even notice it. Sure, maybe it's an eye problem, but maybe it's a brain problem back here. Maybe the brain is not processing that information well. And then final lobe, I don't want to delve too much into anatomy here. Final lobe that I want to tell you about is the cerebellum and the brainstem. This is the animal part of our brain. Helps us balance, it helps us modulate heart rate, blood pressure. So if we've got diseases that affect the way that we walk and coordinate, it's likely affecting these areas. This can also help us coordinate movements. Like, for example, even something as simple as using a pen requires my fingers to have extreme dexterity in moving these fine muscles around, coordinating that writing, right? And then when I'm picking it up, oh, I'm going too far. Oh, I'm not far enough. And then how heavy is the pen? Do I have to grab it like this or do I grab it like this, right? All of this we take for granted until it goes wrong, right? Until it goes wrong and now I can't even hold a pen anymore. But that's the part of the brain that does stuff like that. Now, any dementia can affect any of those lobes. So you'll notice that when I went through those lobes, I didn't say, okay, this is only Alzheimer's or this is only FTD. I didn't say that, right? Because those are all networks. Think of it as functions of the brain, okay? So if we had a disease, it could affect one or two or all of those lobes. And in advanced dementias, they do affect all of those lobes, right? So we're going to go through three atypicals, and they can be caused by, say, buildup of a plaque, okay? But say we're building up a plaque. Do you think that the plaque is just going to stay in one section, or is it going to start building up and, go into other areas of the brain too? And I want you to think about if there is a buildup of a plaque, is it only the plaque, or does it cause other systems to dysfunction as well? That's what I think is really important as we decipher through these syndromes, is that it's never one thing. A lot of people will tell me I got that ApoE gene, doc, so I'm gonna get it. Or some people will tell me, well, I had that really bad car accident, so I'm like guaranteed to get it, right? And it's not. Every single French fry changes the way that our cholesterol works in the brain. Every single cigarette that we had changes our brain. Every single psychological trauma and stress that your brain had to deal with changes the way your brain works. And I describe this by thinking of a car, okay? Imagine your brain like a car that you've had for 50, 60, 70 years. And then you had a problem with the tire, okay? Say that you had a flat tire, but it was just like a little bit flat, so you didn't want to deal with the problem yet. You just kept driving on it. And then what happens? Then our axle has damage, right? And then our engine has to work harder, and then we have other dysfunctions, right? Now imagine if that car already had 200,000 miles on it because you were an avid traveler. That's what our brain is like, okay? Accumulate all of the exposures that you've had in life. Maybe it was stress, depression, anxiety. Maybe it was diabetes, cholesterol, smoking, okay? Add that all up together, and now we've got a problem. Maybe it is buildup of tau, okay? Tau is a protein that can build up and cause FTD, frontotemporal dementias. It's not just the tau, right? It's all of that other stuff that your brain had underneath that led to dysfunction. And when tau builds up, maybe amyloid builds up, maybe glucose changes, inflammation changes. Now the blood cells are breaking down. It's never one thing. It's never one thing, and that's why this stuff is so hard to diagnose. Because we doctors like to figure out things as if it's some scientific puzzle to be like, let's measure this, let's measure that, but that's not how our body works, right? We have layers of systems that are broken, and that's what leads up to the presentation of a disease. So there might be amyloid, there might be tau. Those might be the drivers of dysfunction, but don't forget inflammation, don't forget sugar control, don't forget insulin, don't forget inflammation. All of that plays a role in our brain health, and that's really important. Probably this is the most important slide you're going to see from me today, that it's never just one thing. It's never one thing, okay? And I emphasize this because I think as humans, it's easier for us to blame one thing. It's easier for us to say, I had that one Agent Orange exposure. It's easier for us to say, I got hit in the head. But that leads to a series of things that change, and that's what we need to address, okay? So let me talk to you about how these diseases can look like. Frontotemporal disease, dementias, are actually a spectrum. This graphic is very complicated, and you're going to get a quiz on it later. I'm just kidding. You don't have to remember any of this. This stuff even doctors don't understand. FTD is caused by multiple different proteins and plaques that can build up. The most common presenting or triggering toxin, if you want to think about it, is tau. Tau is a cell breakdown. So our brain cells are neurons, and they look like this, and they're connected like this. And well, actually, we had a picture of one. See, here's a neuron, right? And tau is one of the things that builds up as neurons break down. But it's not always tau. Tau is this one right here. Sometimes it's TDP, okay? Sometimes it's other things like progranulin. And there's just a whole mixture of things that can cause FTD that I don't want you to get too pent up on the actual protein that causes it. The doctors will figure that part out if they have to. But rather, I want you to think about how FTD can present, okay? So FTD has different presentations. It affects the frontal and temporal lobes. Remember, the frontal lobe is our executor, the referee, and the CEO. The frontal lobe tells us when it is okay to say that and when it is not okay to say that. So when a referee is out of town, we might say weird things in public. When a referee is out of town, we might be very inappropriate and have no emotion control, right? When a referee is out of town, we might be very apathetic, right? All of those are frontal lobe functions, and those symptoms that I just described actually can happen with one variant called behavioral variant FTD. This used to be called Pick's disease, and it's a classic picture of somebody's personality completely changing. They might have ritualistic, routined behaviors because that personhood changes. It's a very behavior-specific one. But actually, FTD, you might have normal behaviors and just have language trouble. Because remember, it's FT, frontotemporal. So depending on where the damage is, the protein might be accumulating more in the temporal lobe. Okay, and if it does, there's actually two types of aphasias that you can get. Semantic variant aphasia, semantics is the meaning of a word, means you can talk, but you don't understand how to describe something or what something means, okay? The classic example of semantic aphasia is you might look outside the window and say, I see tall brown things with green stuff hanging off of them. Because we know, like it looks like a tree, but we don't know that word tree. We can describe it, but just our brain doesn't know how to capture the essence of that definition. I had one of my patients with semantic aphasia describe her chair as a sit. She's like, this is my sit. And she didn't know the word chair anymore, okay? Or I've had others describe their elbow as a bend. This is my bend. It makes sense, right? Like they're describing it well. It's a bend, it's a sit, but they don't know the meaning of that word anymore. Versus the non-fluent variant is the one where we don't produce language anymore. And you can actually have mutism with this. There's actually an actor, a celebrity you might know, who has actually become mute from semantic variant FTD, okay? And he's been on the news recently, Bruce Willis. We also have versions of FTD that cause motor symptoms. There's an FTD that actually correlates with ALS. ALS is amyotrophic lateral sclerosis, where our muscles become weak and we don't have motor movement coordination. So nobody ever thinks of that as a dementia, but it is. It can be, right? FTD can also be associated with changes in our eye movements and gaze. That's very specific to PSP, progressive supranuclear palsy. Corticobasilar is another variant where you can have one-sided stroke-like symptoms. I'm not paying attention to one whole side of my body, and I might be shaving one side and I don't recognize the other side. So see how FTD can look like anything. It's not always the classic behavioral, I'm making bad choices, I'm spending money unwisely. I think that's the glamorous, sassy thing that we always hear about, but that's not always what it looks like. Executive dysfunction is I cannot organize, I cannot get my brain to work correctly, and that happens in the frontal lobes, okay? Now, there was a question in the chat box about dementia versus ADHD. They both affect the frontal lobe. By the way, other things affect the frontal lobe. You know what else does? Depression, anxiety, stress. All of those things can make me not focus. All of those things can make me be really mean to my husband, right? Does that mean I have dementia? I hope not. So dementia, remember, is a cognitive dysfunction that leads to functional declines. ADHD is a static process, a neurodevelopmental process that lasts for a lifetime. It does not cause declines. Dementia, by definition, causes functional declines. Also, dementia is typically multiple networks. It's never just executive dysfunction. When you get your workup done with neuropsychology and with imaging, they will often be able to distinguish that it's not just the frontal lobe, but actually there's dysfunction in several other lobes. So there are ways to differentiate it. You don't have to be misdiagnosed. If you're worried about it, go get the workup. Ask another neurologist if they're not helping you out, because we have ways to figure that out. Actually, one of the hardest things to do in my job is figuring out some of these mood disorders. Depression sometimes can look a whole lot like dementia. And sometimes it is the first sign of a dementia process. So that is a very good question in the chat box because frontal lobe is very complicated. You'll notice actually all of the conditions that we're talking about today can affect the frontal lobe. So we could have even named this talk frontal lobe syndromes, for example. So we talked about FTD, that's proteins, plaques building up in the frontal lobe. Sometimes you can get those proteins, plaques building up because of trauma. Sometimes if we get hit in the head too many times, we can have a condition called chronic traumatic encephalopathy. This has been called with various names in society, like punch drunk or punch brain, all these things. And it essentially means our brain is not able to make the best decisions and cognate as well as it used to as a result of too much trauma. And trauma is not just being shaken up once that one time you played football. It actually changes the way our brain works. Our brain is like a jello trapped inside of a hard rock skull. Shaking a jello is going to obscure the structure of the jello, right? Like the jello is not going to be as firm anymore. There's going to be cracks in it. And it might not show up on MRI. It might not be some big old brain bleed. It can just be dysfunction from repeated shaking of the jello, okay? And we need to do more specific tests, like this one, for example, is PET scan. And that's when we can see, okay, that jello is not doing what jello is supposed to do. So you'll notice that there's some pictures here that have bright red. Bright red is actually accumulation of a brain toxin, a brain inflammatory signal, okay, BDNF is what we call it, and it lights up and it tells the whole brain, hey, danger, danger, danger. That builds up in football players with repeated concussions. It can also build up in our military friends who have gone to war and jumped out of helicopters and had trauma from there too, right? And you'll notice that it causes similar inflammatory changes. Similar changes can be seen to a different degree with someone with Alzheimer's. So do you see how when I say everything mixes up together, everything mixes up together? Causes inflammation, causes proteins to build up, it causes blood vessels to change, all of it overlaps. And it can cause a similar frontal lobe dysfunction as FTD, okay? So remember that picture of FTD of someone who's making bad decisions, really mean, really angry? That can happen with CTE as well, okay? Let me tell you about one last class, and then I'm going to take a breather so we can answer some questions. Okay, so here's one last class of atypical syndromes, dementia syndromes I want to tell you about. They're called alcohol-related dementias, the most common one being the syndrome called Wernicke-Korsakoff, okay? Alcohol is a toxin, just like getting hit in the head is, okay? In fact, the Surgeon General now said 0 alcohol is the recommendation for us. Before it used to be just a little bit's okay, but now 0 is what we are recommending. And it makes sense. This is a chemical toxin. Oops. Are you still seeing my screen?
Yeah. Yes, we are.
My slideshow just disappeared. Are you seeing like the Innova login?
Mm-hmm.
Yeah.
Uh-oh. Let me stop sharing just for a second and then log back in, okay? So that you don't all see my password. I'm gonna keep talking while I do this though. Why did it kick me out? So dysfunctional.
I was just thinking the same
I
thing.
just want to share that I could listen to you all day. I have ADD and I am just laser focused on every word that you're saying. And if you have patients and families of patients out there, you guys are so lucky. Just really lucky. Wow.
I appreciate that. That's so nice. I do my best to be one human helping another human. I think if we think of ourselves as too smart or too scientific or above one another, it doesn't make for any fun. But if we say, I am one person who knows something and you are one person who knows something, then it makes things more interesting. So that's how I
Thank you.
approach it, okay?
Thank you.
So let's go back to some of these alcohol things. Drinking alcohol kills brain cells. Okay, there's no easier way to put it. It's a toxin, it's a chemical. I know it makes us feel good, but it kills brain cells. And drinking alcohol in excess is a known risk factor for dementias. In fact, there are very specific dementia syndromes that can happen when we have too much alcohol exposure. Wernicke-Korsakoff is a type of dementia syndrome, alcohol-related dementia, where you have eye problems, where your eye doesn't quite make contact. Like when I'll do my testing, I'll be like, look at the pen. And they're like, I'm looking at the pen, but they're not looking at the pen. I'm like, look over here. And they're not looking, but they think they're looking. So vision changes, oculomotor skills, walking coordination issues, as well as the memory loss. Now, this looks completely different from typical Alzheimer's, right? And that's another reason why it's important to get this stuff clarified, right? Because this treatment is different from an Alzheimer's, right? Now, when somebody has this level of impairment, when somebody has Wernicke-Korsakoff or another alcohol-related dementia, it often means brain cells have died. Okay, do you see these white spots in the brain right here? That's bad. Okay, that's brain cells that have been damaged. So if I can help treat your problem, your alcohol addiction or alcohol dependence early, and we get you the thiamine and the glucose that you might need, and the rehab and the psychology that you might need, we can prevent this from happening. But a lot of times, just quitting alcohol 5 years ago after these changes are seen is not going to be enough. Okay, so I do got to warn you about that. This is like end stages, a result of all of it. Now, this is probably my last slide that I want to go over because I want to stop talking. I feel like I'm talking too much. Here's a really important slide. Lancet is a big old British journal that tells us really important things about dementia prevention. And I want to point out a couple of things. They publish this paper called the Commission on Dementia Prevention every couple of years. And in 2017, they published this graphic, okay? And it had a whole bunch of things, our birth or hereditary. I saw a question about hereditary and, how much that contributes to dementia and how much hearing loss contributes. And they eventually ended up with this number of potentially modifiable 35% of things. Like maybe if we got hearing loss fixed early, we could prevent the onslaught of dementia later. But I mean, there's a lot of things we can't change, like ApoE status, we can't change. That's something we're born with. But look at this trend here. That was back in 17. In 2020, they republished with additional data. That's 3 more years of data. And now there's 40% of stuff that we can modify. They added onto it actually alcohol use. If we can control midlife alcohol consumption, we can modify the occurrence of later life dementias. They also added on air pollution. That's something we can do less about, but we could at least be aware of. They added on physical inactivity. So midlife and later life inactivity is a modifiable risk factor for dementias. Here's the exciting news. The most recent one was published last year, 2024, and it's got 45% risk factors that we can modify. So when people ask me about, well, I've got 3 generations of Alzheimer's in my family, I know I'm going to get it, I'm just going to start preparing right now. I want to tell you that there is a 45% modifiable variables in your life right now. That I have plenty of patients with 4 or 5 generations of Alzheimer's. I have plenty of patients who should have Alzheimer's or other dementias based on their risk factors, but don't. And that's because genetics are not all of it. we actually don't routinely check ApoE status. We don't routinely check for those FTD panels, and all those genetics are actually not even covered by insurance because they don't actually lead one to a disease presentation. They might help us understand a little bit better, but genetics is not the biggest deal. It is a contributor, and I want to know about your family history. Please tell me. But I am never going to say you're doomed from the start. It's not like some of the genetics out there for other medical conditions, like for example, the breast cancer gene. If you've got it, you're going to get it, kind of a thing. That's not what it is for these kind of dementias. So genes are just part of the picture. I usually say it's about 30% of your picture is genetics. Another 30% is your lifestyle. So what we eat, what we smoke, what we drink, how we sleep, our mood. Then the last 30% are some of the question mark, I don't know what else to do, like the pollution, your in utero exposures to how stressed your mom was, falls under there. Like that stuff we can't do anything about, right? So 30% genetics, 30% lifestyle, 30% I can't do anything about it. It's kind of an unknown variable. So I hope that after all this talk, it gives you some hope that there are things that I can change. There are things that I can do. There is no 100% proven preventative measure for dementias. But as we learn more and more about how our brain changes, there's a lot of things we can do to protect our brain too. So that's kind of where I wanted to kind of sum up and then let you guys ask me questions.
I'm so impressed. And let's start with our caregiver expert team. This information has been so valuable, and there was a lot of questions. I'll just remind the audience that you will receive a copy of this presentation to share with friends and family, and probably keep it on your desktop for reference. That was just so wonderful. I just can't thank you enough. And I think we're going to start with Lisa is going to start us with some questions, and audience, please again submit any questions to the Q&A.
Okay. What are the current challenges in accurately diagnosing any of these diseases, the FTD, the CTE, and alcohol-related dementia during our lifetime?
Time. The only way to 100% define many of these biomarkers is with autopsy or brain biopsy. And we typically don't go around taking chunks of brain out to kind of look at it under a microscope. We're getting better. We've got skin biopsies, we've got CSF, spinal fluid biomarkers, but many, like tau, is really hard for us to define. There are PET taus, but that's only in the research space right now. TDP-43, another one. Like we understand that it's there and we can see it on autopsy. We have no idea how to measure it. So we don't have the measurement tools for all of these protein plaques is one barrier. Another barrier is that it's often a mixed bag. Remember, it's often a little bit of amyloid and a little bit of tau and a little bit of this that someone might present looking like Parkinson's, and then we realize there's also an Alzheimer's dysfunction going on. And so time is my greatest tool in understanding a lot of this. So when I hear stories about it took me 5, 7 years to get a diagnosis, that's horrible. That sucks. I'm sorry. But it could be that we didn't have enough information. That actually the chronology of how things changed is what helped the doctors understand better how the brain was changing.
Dr. Pauldurai, I wish you had been our neurologist for sure. And I could listen to you all day long too. And it is the behaviors, and it's the behaviors that affect the family, and it is a family illness and the stress on everyone in the family. What do you say to the families that are having a really difficult time getting the diagnosis of this disease?
Yeah. I tell them that the least we can say, even if we don't know what specific thing is changing in their brain, is that there is a chronic neurologic illness. There is something that is causing dementia for your loved one. So prepare yourselves for a journey. And what that means is you don't have to go and read all the things. What it means is be gracious to yourself. Be patient with yourself. Understand that your person is going to change. It's not just like a broken finger this is a broken brain, and the brain is what makes us who we are. So when the brain changes, it can change every day, every hour. We might have a good minute, 1 minute, and then the next minute you're like, what happened? So give yourself grace and say, this is a field that even doctors are struggling to figure out what's going on in my loved one's brain. So let me take a breather and let me know that I will not know all the things. I'm going to do my best to pay attention, but if I mess up, that's okay because this is a chronic neurologic illness and this is something that I'm going to learn to survive through. It doesn't mean suffer through. We have ways to help someone not suffer, but it is something that we will live through and hopefully thrive through, is what I hope.
Dr. Pauldurai, if I may, what you just said sort of relates to a question that we have in the chat. Two different questions that I'd love to see if we can get your thoughts on. One, asking about current treatments for these specific conditions. And then I have another one too. But if you could, are there any current treatments for these specific dementia diagnoses?
There are symptom-based treatments. So when I say that is if you have a symptom of, say, mood instability or a mood change, I have ways to make you less angry. I have ways to make you happier. So I have medications, we have therapies for that. If somebody's not eating well, I can make them eat more. If somebody's eating too much, I can make them eat less. If somebody's sleeping too much, I can make them wake up. All those things are symptom-based medications that we do have on the market. We do not have disease modifying, disease curative therapies for any of the ones that we talked about today. There was another condition in the chat box. I'm just perusing through it. Sorry if I missed them. Normal pressure hydrocephalus, if caught early, is a reversible type of dementia. If we can shunt the fluid away from the brain, that is treatable. So that is another condition that we won't go into the details of today, but that's one that does have a treatment. Alzheimer's does have a treatment. So no specific curative measures for these ones, okay?
Okay. And then I guess that also ties into the next question too. How can an older adult best advocate for themselves for proper screening and diagnosis? I think that's one of the things that I'd say when we've been prepping for these presentations is how do we empower families or a person with who's experiencing dementia symptoms to push for that, not just dementia diagnosis. So
Yeah.
what do you recommend to be able to give people the best tools in talking with their primary care or how to push on knowing that behavioral neurologists aren't available in all communities.
Right.
And
Right.
so what do you recommend in this situation for people to get
Yeah.
proper screening and proper diagnosis?
Here are the key words. Okay, ready? Flag these words. This is a significant quality of life changing thing that I care about for me and my loved one. This is changing my life and it is putting me at greater risk for other illnesses. Doctors don't want you to get sicker. Okay. I want you to pay attention to me because it is contributing to my quality of life. And even if there is no cure, or even if that, I want to know what is going on so I can better take care of myself and my loved one. After age 65, Medicare requires an annual memory screen, but you can ask for that before if you say, I have family history and I notice that my thinking is different. Just say it. Just say, I am noticing changes. I want to get the screening. Often screening will be done bedside and I might not notice it. You might not pick up on anything. So say, what else can I do? I am still feeling something. I know you reassured me, but what other tools do we have to help address my symptoms? Might be cognitive rehab. It might be a neuropsychology test. There are things that they should be able to refer you to. And if your primary care doesn't know that answer, perhaps ask somebody else. Just keep asking. Come to these webinars, come to educational events. Somebody will say something where you're like, oh, I need to look into that.
Great. Thank you.
And I have a question. One of the questions I'm often asked in my private practice is, how do I know the difference between a personality mental illness disorder and dementia? Let's use mood disorder, bipolar, right? And then how do we distinguish between it being a mood disorder and or potentially a form of dementia?
It's probably both, is my short and easy answer. Everybody comes with baggage, everybody comes with personality, and no one person with FTD ever looks like another person with FTD.
Yeah.
No one person with Alzheimer's ever looks like anyone else. It makes my job very complicated.
Yeah. Yeah. Thank you
Just,
for that answer.
just know that it likely is a mixed picture. So if
Mhm.
you are noticing mood symptoms or have a history of mood symptoms, have psychiatry on board and have the neurologist on board.
Okay. Thank you for that answer.
I want to talk,
Muted.
sorry, I saw a couple of questions in there about the skin biopsy, so let me just kind of address that. There is a skin biopsy for Parkinson's, there's a skin biopsy for Lewy body. Now, I don't know if I like it yet, but there is a skin biopsy for Alzheimer's disease too. So there are ways to gather those biomarker data points. Movement specialists can do it, different cognitive specialists can do it, so you could ask for it. There's different ones though. So let the doctor guide what they think is the next best thing. Like I wouldn't go and skin biopsy everyone. It just might not make sense for you, right? So start with the appropriate steps. Get a cognitive picture, get a good story, maybe get an MRI, and then if they deem a skin biopsy necessary, they'll lead you in that direction.
We have just a good time for a couple more questions. One of you ladies want to take the floor?
Yeah, one of the things I think comes up a lot when we talk to when we're talking with families is the world of, and it's a question in here, which I think is great. It's like, what do you say to someone who's clearly showing symptoms, but they're in extreme denial? And I know sometimes with dementia, it's not that they're in denial, it's just that they don't realize that they are experiencing those symptoms. And I think so many families really struggle with that. So can you help answer that question a little bit?
Yeah, I always say try to put yourselves in your loved one's shoes, okay? Imagine if you have been some top-notch dementia doctor all your life and you've been driving on your own and somebody knocks on my door and says, I'm doing it all wrong. Somebody knocks on my door and says, You're messing up, Jen. You did this wrong, this wrong, this wrong. Just stop lying to the doctor. What? I'm not lying, right? In my view, I am doing just fine. So I know it's hard. I know it takes patience, but put yourself in their shoes and understand their reality. Challenging them with your reality is not going to work, right? If I fully, firmly believe that I'm an excellent driver, I'm an excellent driver. Nobody in the world is going to tell me otherwise, okay? So you telling me or showing me video proof of me crashing my car is not going to work either. I'm just going to distrust you. I'm just going to say, You're lying to me. I thought I loved you. I thought you loved me. So we get to their reality and try to find a common ground. It might mean, hey, mom, I know you've always been wondering about, how you have trouble finding those words. Like your memory seems to be really good, but I know you're worried about word finding. Why don't we go see somebody about it? Because, I really want you to stay independent and have your way. You care a lot about your garden and living in this house for a long time, and I want to respect that. I love you and I want to empower you. But I think if we get this addressed, you would have a better chance at fulfilling your goals is much easier than Mom, you keep forgetting I think you need a dementia evaluation. I wouldn't play along with that either, right? Meet them where they are, find a common ground, always show love and respect.
And there is damage in the certain part of the brain where self-awareness is stored, right?
Pride alone,
Right. So no matter, I'm visually impaired. I can only see what I can see. So
right?
you can tell me anything and everything. If I can't see it, I can't see it. And I think that's a huge factor separating. It's not denial. It truly is damage and inability to see what I
Right.
can't see.
Yeah. And some of it might be stubbornness, some of it might be personality, but a part of the brain cannot recognize that there is a problem or the severity of the problem. So don't force it.
Yeah.
What a great way to end with respect of the condition. But I also think we should end with, for everyone listening today, it really does what Dr. Jennifer said. It's a family disease. Someone said, I think it was Dr. Jennifer, and that's what you really work with the family. So don't try to do any of this alone. Get your team together, your family. But Dr. Jennifer and Monica and Tammy, and I just cannot thank you all enough, Lisa, for joining us today. And that presentation, I can't wait to rewatch that, and I'm sending it to my friends as soon as I get the copy. So I listened to every word. That was fantastic. So thank you so much.
Thank you for having me. I really, really appreciate this. This is, like I said, an opportunity that all of us have to make use of. Every single chance that we talk to someone else, we could learn something new. So I really appreciate that.
It takes a team, and we're a team. And if you're on the West Coast, enjoy this beautiful afternoon and weather. And if you're on the East Coast, good luck. No, just kidding.
Thank you, everybody, for joining.
Yeah, thank you so much.